Welcome to the American College of Cardiology's Conversation with Experts. Now in this segment we're going to look at the latest scientific breakthroughs, or knowledge really, that has come from the Heart Failure Society of America's 2013 annual scientific session. I'm glad you're with us. I'm Dr. Randy Martin, joined by a great panel, very distinguished panel, knowledgeable panel. To my immediate left is Dr. Clyde Yancey. Clyde is Chief of Cardiology at Northwestern University, the Feinberg School of Medicine. Good to see you, Clyde. Marielle Jessup. Dr. Jessup is Professor of Medicine at the University of Pennsylvania in the Heart and Vascular Center. Marielle, good to see you. And Dr. Jim Januzzi. Jim is Professor of Medicine at the Harvard Medical School and is the Director of the CCU, the Cardiac Care Unit at Mass General Hospital. Jim, let me start with you. A lot of information on novel biomarkers for heart failure. What's new? Are these going to change the way that we direct therapy in heart failure?
Well, it's a great question. Let me start off by saying that biomarkers are nothing more than a supplement to clinical judgment. That's the way we should really be thinking about them, right? But it helps us to define our patients in more than one dimension. So there are things that clinical judgment tells us that are far more important than what a biomarker can tell us. And similarly, there are things that biomarkers can tell us that we just simply can't tell without functional imaging and other types of ways of looking at patients. And the attractiveness of markers is that they reflect biology. They may reflect future risk that we cannot otherwise predict. They may impart knowledge of processes that we can't tell are present in any other way, so ventricular remodeling, for example. But again, they supplement our clinical judgment, and they should inform paths that we can then employ in these patients to improve their outcomes.
So Clyde or Marielle, what are your thoughts on some of the new novel, and what are they? So, you know, again, speaking as an outside guy that's used to looking at echoes and you know, valvular regurgitation, those sort of things. What are some of the new novel biomarkers?
So there are a couple, and these actually are articulated in our current guidelines. But in addition to the natriuretic peptides, we have galectin-3, and we have yet another one, ST2. And to Jim's point, they really give us additional information. So they now infer that there is a fibrotic process that is going on in addition to changes in ventricular structure, shape, and function. So the important question is, yes, we have additional tools, but to what extent does it give us additional useful information to help us better manage our patients? We know that there are some synergistic predictors, that is to say that when natriuretic peptides plus one of the others are both equally elevated, we have higher indices of concern, but we still have to understand, how do we behave? What do we do differently for the patient?
Absolutely. Marielle?
Well, it's hard to take care of heart failure patients, and we'd all like a hemoglobin A1C for heart failure, and it would be nice to say, oh, this number's too high, keep doing what you're doing, or do something different to your patient with heart failure. And it's not clear whether we can use these biomarkers to help this. I think we probably should be, because for instance, as we're all working to reduce readmissions in heart failure, you can't use all of your huge long team on every single patient that comes in. So it may be that a combination of biomarkers will say, here's a really high-risk patient. We have to do everything we know how for this patient. And these other patients, because the biomarker and because our clinical sense suggests that they probably will do pretty well. So that's the goal, is can we use these not only to predict risk and focus our limited resources on those high-risk patients, but it might even help us decide, let's put in a VAD, and we didn't recognize how sick they were, or let's start the process of heart transplant evaluation because they look all right, but come to see the biomarkers really tell a story that we didn't appreciate. So I hope it'll help.
But Marielle, you get to a good point, because originally, Jim, we just focused on this as a tool for diagnosis.
Right.
And we're so far beyond that now.
Yeah, so, you know, markers...
That's what I wanted to, I was going to say, so how do you incorporate these into clinical practice?
Sure. So, you know, we can distill it down to 4 simple ideas for the viewers. One is markers can be used to identify the presence of a process, a disease process, heart failure, for example, if we talk about natriuretic peptides. They can be used to identify risk in that disease process, and that's where a lot of efforts have been focused recently with respect to the natriuretic peptides and these novel markers. They may tell us that a patient should receive a therapy, of sorts, and we can discuss some specific examples in a second. Or, as Mariel said, they can also tell us what not to do for a patient. And I think, each is independently useful. There are, for example, data with galectin-3, a marker that Clyde mentioned, that show that if the marker is elevated, patients actually do not benefit from being put on a statin in the setting of heart failure. So patients with an elevated galectin probably have an immutable risk from heart failure such that treating coronary artery disease may not necessarily favor them. On the other hand, the low galectin identified patients who very robustly benefited from statin therapy in the Corona trial, for example. But really, what people are hoping for is, as Dr. Jessup said, is the opportunity to take a marker and say, this marker is elevated, I will reach for this therapy. And we actually have some interesting data. We've been doing a lot of work on the vanguard of this concept, looking at this idea of using biomarkers to guide therapy, whether it's with natriuretic peptides or with some of these newer markers. We have data that are currently in press, for example, just as an example, showing that ST2, a very potently prognostic marker, probably one of the best, if not the best, of the latest new markers, specifically responds to beta blocker titration. And so we can see the circular link between the marker predicting benefit from the therapy and the therapy lowering the concentrations of the marker, such that patients with very high ST2 values who are titrated to very high beta blocker doses have a considerably greater benefit than patients with lower ST2 values.
Interesting. That's very, very interesting. Let me play the payor nihilist in this. So are these very expensive? Are these rapidly available tests? As we add more biomarkers, which you're making a great case for, is this going to be cost effective?
Well, let me take that one on because we work so much with markers. Compared to an echo, compared to an MRI, they are dramatically cost effective. But the key about cost effectiveness is the response that you attach to the value of the result of the test. They are not cost effective if you just measure them and do nothing. They are rather cost effective, as an example with, say, natriuretic peptides for diagnosis or for management. We have cost effectiveness data now with respect to therapies triggered by natriuretic peptide values. If you respond and respond well to the value that the test is telling you, they can be actually quite cost effective. They are widely available. Some of the newer assays like ST2 are now going to have a point of care assay available in the next few months such that they can be measured right at the bedside.
I mean, I was being a little bit facetious because ejection fraction is looked at and is just not a really good marker. I mean, it's really...
But don't forget about cost avoidance.
Yeah.
Because if they direct you correctly so that you're not doing additional diagnostics that would be of little yield, then that helps you. And as time goes on, the field is not yet completely mature. As we really determine if biomarker-guided therapy improves meaningful clinical outcomes, we know that it allows us to optimize doses of evidence-based therapies. But when we show that we can improve outcomes, then that changes the calculus completely.
No, I mean you're making a great case. What about kidney? The kidney is hanging out in this syndrome of heart failure. Do we have markers that tell us about kidney function that are new and really exciting?
I think that's what people are looking to galectin-3 for as a measurement. But realize that the vast majority of heart failure is taken care of by non-cardiologists. And ideally, we can use these, just like we've used in other diseases. Everybody knows how to recognize troponin, which is a biomarker, and say, this patient's in trouble. Everybody knows how to look at elevated LFTs and say the liver's in trouble. So what I hope for is that we'll come up with a nice, clear picture of biomarkers so that everybody, internists, ER docs, can say, this is heart failure and this is what I need to do. So that's what I'd like. And whether galectin-3 is going to help us say, this is heart failure and the kidney's in trouble, we have to know how to respond to that first before we can spread that news.
So, galectin as a marker of fibrosis rises in all organs that are injured. Dr. Jessup measured troponin, and what people are hoping for is a troponin for the kidneys. So whether it's, markers, there's an alphabet soup of emerging markers, NGAL, KIM1, NAG. interleukin 18, penenkephalin. There are dozens of potential markers that rise for all sorts of reasons when the kidney is injured. But it is very early at this stage to understand, with respect to the understanding rather, of why they rise.
Right.
Does all forms of kidney injury cause all of these markers to rise, or do some rise from ischemic ATN, do some rise from nephrotoxic ATN? The key here, though, to emphasize is that while worsening renal function is something that we've all feared in heart failure, we've come to realize that not all worsening renal function is created equal. And whether it's the results from the DOSE study or the CARESS-HF study that showed that you can actually cause worsening renal function from good care,
right,
and the patient actually does fine. What's interesting there is that renal biomarkers like NGAL, which is a marker of tubular injury, in those patients who actually get very dry and have a rise in their creatinine, the NGAL values don't go up very much. And that therefore identifies the good acute kidney injury, as opposed to patients who come in dramatically congested and have kidney injury on the basis of cortical congestion of their kidneys. And that's the bad worsening renal function. And there, either urinary or blood biomarkers of renal injury may be very useful for identifying that specific group.
So let me ask you in summary, where are we headed with biomarkers? I mean, you said it's an alphabetical soup, and it certainly is. Where are we going to be in 3 to 5 years with biomarkers? You made a strong case, Jim, about directing therapy and all that. Mariel, where are we going to be?
I mean, what I hope where we're going is that we're going to use these as tools to clinical judgment and as a way of setting up better algorithms for care to identify the high-risk patient, identify the patient with end organ disease, to help us triage patients. So ideally, it could be put into our electronic medical record. So we can have decision support, even if you're not very knowledgeable about the alphabet soup.
Absolutely. Claude, your thoughts on where we're headed?
Well, I like to think about where we've been. We've gotten over the initial joy and exuberance about, man, this is the thing, this is all we need. And we've positioned it correctly, and we know how to use these biomarkers, particularly for diagnosis. And now we're talking about risk stratification and prognosis and guiding therapy. And if we make the same steps forward in another 5 years and have the kind of fidelity of our information, then that will benefit everyone, because, as Jim said, heart failure is the disease du jour for the next 10 years. So get ready.
At least. Jim, you agree that this is the direction we're headed?
So I would say that we've gone a long way in a short period of time with respect to the markers that we have available to us. I would say that as someone who works in this space, we probably have far too many markers and need to focus down on the specific few that are of greatest value. We are now doing a pivotal multi-center trial sponsored by the NIH called the GUIDE-IT-HF trial, which is a study that will examine the potential value of natriuretic peptides to guide outpatient ambulatory heart failure management. That is the next big step, and once GUIDE-IT is completed, we'll have an answer as to whether the small studies that suggest the benefit of this approach were actually correct. And if that is the case, then we have something, that we can really bring to our patients that's of great value, I would say, which is the objective, biologically driven approach to their heart failure care.
Yeah, that'd be very, very exciting times, and I think you made the point, putting this in an electronic medical record or simplifying it for the non-heart failure specialist who's dealing with that patient is very important. Great information. I've learned a lot, and I always do from you all, and thanks very much for joining us. We hope that you'll stay tuned and come back for more.